Let's get right to our discussion on genetics. I'd love to tell you a little bit about our experts. Dr. Alexandra Sokolova is an assistant professor of medicine in hematology and medical oncology at the Oregon Health and Science University School of Medicine. Her research focuses on helping prostate cancer patients and those with hereditary cancer syndromes to live well. Justin Lorentz is a certified genetic counselor through the American Board of Genetic Counseling. He practices clinically at the Sunnybrook Odette Cancer Center in their Cancer Genetics and High Risk program and is an instructor at the University of Toronto. Welcome to you both. We've got several things to discuss here, and I know genetics is such an important and sometimes confusing topic, so I'm grateful for you joining us today. So Justin, I'll start with you. What is the difference between germline and somatic or tumor testing? As we know, there are some different names that come about with these.
Yeah, it's a really good question. Whenever a patient tells me that they've had genetic testing, my next question is, okay, well, what kind of genetic testing have you had done? In today's world, there are multiple types of genetic tests that are commonly done. 10 years ago, there's kind of just one that we were thinking of. And so the two main genetic tests are genetic testing of the tumor itself, so the cancer itself, and then genetic testing of what's called the germline. So I really want to start with the germline piece to that because it's a bit of a jargony word that I would love to really be a household term that we use. Just like we use the word germinate on a regular basis, I feel like germline can fall into that same bucket eventually. So germ is the Latin word referring to seed or a bud or an embryo. So things like germinate, wheat germ all come from that. And so germline testing looks at genetic changes that we inherit from either the egg or the sperm that fertilizes the egg, and that makes us who we are. Germline genetic changes are rare. They don't happen very often. Very few families have these genetic mutations that are passed on from generation to generation. It only accounts for about 10% why cancer happens. And so when it comes to these, where the sperm does fertilize the egg, and if there's a mutation in either the sperm or the egg, that means that the embryo and the baby that develops with that has a mutation in every single cell in their body. And so when we do germline genetic testing, we can test any cell in the body. It's just that we typically like blood and saliva because they're really easy tissues to access, and we can extract the DNA from that. But we could take a skin biopsy, we could take an eye biopsy, but all that stuff's pretty invasive. So we just use a saliva sample or a blood sample. When we find a genetic change in the saliva or blood sample, we just assume that that's present, that genetic change is present in every other cell of the body. As a result, if someone has a germline genetic mutation, it could impact more than one tissue. So we think of, the genes that are commonly associated with prostate cancer may also be associated with breast cancer in men, pancreatic cancer, because those are other tissues, because other cells also have that genetic mutation. If someone has a germline genetic mutation, they've inherited it from the sperm or the egg, so they can also have a chance of passing it on to the next generation. Genetic testing companies that do germline testing are companies like Invitae, Myriad, Color, Ambry Genetics, GeneDx. The long-winded answer for at least one part of this, the other one I want to get into is the tissue testing, the second type of genetic testing that we do. This is called somatic testing, it's called tissue testing, it's called tumor testing. And essentially what we're doing is we're looking at the cancerous tumor itself or the specific tissue to see what mutations are present there. And when it comes to looking at the mutations present in a cancerous tissue, we will find so many mutations. And that's because all cancer is caused because of multiple genetic mutations. And interestingly, if we were to take tissue right next to the cancerous tumor, the healthy tissue, we would find no mutations, unless there's a rare instance where there's a germline mutation, all tissues impacted. But typically, if we find a whole bunch of mutations in the cancerous cell, the healthy tissues next to it, healthy cells next to it, we won't find anything. And so the reasons why we do this type of testing, the genetic testing of a tumor, is to see, hey, if there are certain mutations, are there certain therapies that can target those mutations specifically? The results of a tissue test or a somatic test just are helpful in managing that cancer. They don't have impacts for other family members, largely. And so companies that do types of tissue testing are companies like Polaris, Decipher, Oncotype DX. And so the germline looks at things that are inherited that increase risk because there's genetic mutations. And then somatic testing is just looking at the cancer itself to see if there's any mutations that are there or what types of mutations are there, because there's always mutations present. Long-winded, but it's a tough, simple question, tough answer.
Yeah, no, well, thank you for that distinction. That was helpful. So Justin, back to you. Who should consider germline testing, and what do the recommendations and guidelines say?
Yeah. And so the answer of who should be considering germline testing is pretty complex as well. In the world of prostate cancer, there's one really big factor that makes us think, hey, we should be looking to see if there is an inherited risk of germline genetic change that might be associated with that person's risk. And that is what's called metastatic prostate cancer. So a prostate cancer that's spread to other parts of the body. That is a pretty well-known indicator. And in individuals who have metastatic prostate cancer, about 11 to 12% have a genetic mutation, which is a high chance in the world of genetics. And so anybody with metastatic prostate cancer. Now, there is this guideline called the NCCN, National Comprehensive Cancer Network, that makes rules for when we should start thinking about people getting genetic testing. And they came up with a fresh set of rules as of last month. And so metastatic prostate cancer being one. And then individuals who have certain types of specific types of cancer, ones that are considered to be high risk or very high risk. If there's something called an intraductal component to cancer, that's a factor that we think about as an indication for getting genetic testing. The other thing is family history. So if an individual has prostate cancer and they have a family member with a triple negative breast cancer, with breast cancer diagnosed at or under the age of 50, an individual who has in the family who has male breast cancer, an individual in the family with ovarian cancer, an individual with pancreatic cancer, another individual with metastatic prostate cancer. All of these aspects of family history in the context of someone being diagnosed with cancer themselves, prostate cancer themselves, are indications to start thinking about doing germline genetic testing. We also know that individuals of Ashkenazi Jewish ancestry who have a personal history of prostate cancer, good indication for genetic testing, because individuals of Ashkenazi Jewish ancestry are 10 times more likely to have a genetic change in the germline than people who are not of Ashkenazi Jewish ancestry. So the NCCN is a pretty commonly used guideline, but a kind of universal guideline across the world of metastatic.
Oh, can you speak up? Okay. We just lost your volume there for a little bit, just at the end.
The metastatic prostate cancer is the internationally the criteria for thinking about genetic testing, but there's some more refined criteria in the US.
Okay, great. Thank you. That's really helpful. So Dr. Sokolova, now that we've discussed germline testing, so who should consider tumor or somatic testing? And similarly, what do the recommendations and guidelines say?
That's a very interesting question. I think when we think about who needs to get testing, it's important to ask, why are we doing that? And I would say that germline testing has overall a broader implications for why we test it. One of the implications that is shared with somatic testing is treatment implications, but it also has a broader implications. It has other cancer screening, it has family implication, it has prognosis implications. When you think about somatic testing, I think the kind of largest implication of somatic testing is treatment. So everyone who the somatic testing could change treatment for should get somatic testing. The NCCN guidelines do recommend somatic testing for our kind of BRCA-like genes for everyone who has metastatic disease. because we have treatments that we can use if we find those genes. It does say consider this testing if people have a regional disease, meaning it's advanced but not really metastatic yet. And that's because there could be some implications, some clinical trial implications, or a large proportion of those patients will progress to becoming metastatic, and knowing those mutations early on can help us to plan treatment. When we talk about the second set of mutation that we test for, such as microslide instability or mismatch repair deficiency, kind of our Lynch group of alterations, NCCN guidelines do recommend it for everyone who has metastatic castration resistant and considering it an early disease space. So as a blanket rule, everyone with metastatic disease should get somatic testing. And it's not somatic or germline. People with metastatic disease should get both because they provide a little bit of different testing, a little bit of different angle. And so if someone qualifies for both, they should get both. I would also say that now with so many clinical trials available, there could be opportunities for someone with a localized disease or a regional disease to be part of a clinical trial. So if they're centrally treating, they're a clinical trial kind of targeting this specific population, your doctor might be talking to you about doing this testing even earlier on. But as per guidelines, kind of standard of care, everyone with metastatic disease should be thinking about somatic testing. I think it'd also be important to talk about kind of how we do somatic testing and what it is, because there's a little different flavors of somatic testing. When we talk about somatic testing or tumor testing, we want to see which mutations happen in the tumor as tumor was developing. And we can test it by either taking the tumor tissue itself, so biopsy, and that could be a biopsy that was done earlier and stored somewhere in archives, and we can retrieve this biopsy and look at mutations, kind of the original biopsy, or we can do a fresher biopsy, newer biopsy, and we often go for a metastatic site. And the nuances there with an older tissue or older tumor sample, we see kind of an earlier developments in the cancer. So we see mutation the cancer had earlier, and sometimes over time, the DNA or what we test degrades, and we're not able to get a good enough of a reading. The rule of thumb is probably anything over 10 years old might have some limitations of testing on it. So anything within the last 10 years, we can try to test and see if we find what we're looking for. And so if we're looking into the fresher tumor biopsy sample, it gives us a fresher tissue, so probably high chance of successful testing. It also gives us a kind of a later clone. The cancer evolution, it started as something, and then as we treat it, it develops into, it migrates and evolutionizes to adapt to live through treatments we have. So it develops new mutations and develop new alterations. So by biopsying a fresher or kind of newer metastatic site, we're probably looking at a snapshot of a later tumor clone that might be more relevant to treatment right now. We also have a different method of doing tumor testing, which is circulating tumor DNA. And that's a more newer technology that we've been using. And tumor kind of sheds some of its genetic material in the blood, and we now have technology to pick it up. So we don't necessarily have to do a biopsy. We can just do a blood test and then look for tumor DNA in the blood and do genetic analysis on it. It also has some limitations because you do need to have a certain tumor volume to pick it up, this DNA, because if it's just a little bit DNA, it might be hard to pick it up. It does correlate with the PSA levels. So the higher the PSA numbers, probably the more of a tumor volume, the more of a tumor shedding, and the higher chance it will actually be able to pick up something in the blood. It does also give us kind of a later snapshot of a tumor, kind of later mutations. But when we talk about tumor testing, we think about, are we going to do it archival tissue? Are we going to do a new biopsy? Or we're going to look at just the blood DNA? And there's no rule of thumb. I think it's very individual, but I've kind of shared some of the considerations we do.
Okay, great. Thank you for that. So really, patients, if they're wanting which test might be right for them, another biopsy, testing the older biopsy, whatever. It's just they should talk to their doctor about that thing. Great. And just to reiterate, you did say, if I heard you correctly, that metastatic prostate cancer patients should get both germline testing and somatic testing, correct? I think that's important. I just want to highlight that again.
Yes, thank you for highlighting. I think this is something that's sometimes gets misinterpreted or missed because, well, you did one test, why do you need the second one? The genes are everywhere. But yes, you're right. If you do germline testing or if you do somatic testing, you would be getting DNA, but our tests are designed for different purposes. And then they should be used appropriately. So if someone is qualifies for both, and everyone with metastatic does, they should get both tests done.
Great. That's an important point. Thank you. So Justin, what is the process for getting genetic counseling or testing?
Yeah, and so I guess the caveat here is that we're going to speak to the germline process of the genetic counseling and genetic testing piece. There's a few different ways that people can access genetic counseling or genetic testing. And the reason why I differentiate them is because not everybody who gets genetic tested may do it through a way where they meet with a genetic counselor. A genetic counselor is someone like me. I'm not a physician. I am a genetic specialist. My skills are to interpret genetic test results, explain genetic test results, facilitate genetic testing. And oftentimes the gold standard of how our profession says we should be doing this genetic testing process is to meet with someone right up front and say, hey, we could do genetic testing to look at the genes that you've inherited, to see if there's any genetic versions of those genes that might increase your risk for cancer, why you got cancer. And then the reason why we have this counseling piece is because we say, hey, if we find that you have this gene mutation, it could have implications for you and for family members. So after we have that conversation, and I'll talk a little bit more about what the implications of a germline genetic test can do, but after we have that conversation, we facilitate the genetic testing. The genetic testing comes back. We have a conversation, a post-test counseling discussion to talk about the results. Now, the way that this process happens, traditionally, it was through a referral process where you get referred to meet with a genetic counselor to facilitate that testing by your doctor. Now that genetic testing is happening so much more often, there's so many more indications, and there's such high volumes, we're changing our models of care. Instead of us doing this ideal scenario where you meet with a genetic counselor before doing genetic testing, that's not feasible as much anymore. So now the models are changing where maybe somebody will do an educational video and their physician will initiate the genetic testing process. And maybe after the physician orders the test, the result comes back. You may meet with a genetic counselor depending upon the results. Sometimes you automatically meet with a genetic counselor. It depends upon what the model is that the institution that you're working with uses. Other ways that people can access genetic testing is right through a company like Color. They don't need a physician. They can order the test themselves, and they'd be paying a fee for that. And then they would get a saliva sample sent to them by mail, send the saliva sample back, get a report back, and Color provides a genetic counselor that you could speak with about your results. The last method is through something like a clinical trial. For example, there's a PROMISE registry that's available for individuals to get genetic testing at no cost. The way that genetic testing is facilitated is you enroll into a registry, which is basically just a group of people who have something in common, and that being that they have prostate cancer and they are going to be getting genetic testing. And then the clinical trial will facilitate the genetic testing, and then there'll be options for genetic counseling after as well. So these are the different kind of avenues: referral-based process, a physician-initiated process, a patient-initiated process, and then joining clinical trial. Four kind of general routes that are there.
Thank you. And we'll hear a little bit more about these clinical trial options later. Dr. Sokolova, what mutations are found most commonly as a result of testing, such as, we've heard of often BRCA1 or 2, but tell us, I know there are more and it's hard to keep track of. Tell us more.
In prostate cancer, the most common mutation that we do find is BRCA2. That's the most, I would say, impactful mutation and the most common one. It's followed by ATM and CHEK2, BRCA1, and then there's a plethora of other ones that are a little less prevalent, PALB2, RAD51, ATR, NBN, PMS2, to name few. But I would say the BRCA2 mutation, it's the most prevalent, and it's the one we understand the most, the one that responds to our targeted treatments the most. Out of all kind of DNA damage repair mutations in germline setting, it probably represents about 40-ish%. BRCA2, and then the rest 60 is shared between the rest of mutations, with ATM being around 13%, CHEK2 being around 12, BRCA1 being around 7%.
Great, thank you for that. So let's talk, you mentioned treatment, so let's talk about that. What are the implications for treatment for patients?
So the treatment implications are standard of care or clinical trials. And a clinical trial is a very fast evolving space, and it will be depending on location or particular time. So I would say you should always talk to your doctor about what are the clinical trial implications for this testing. Do you have anything if I were to find a mutation? If we talk about standard of care, then there's two potential implications. If we find anything in our kind of microsatellite instability, mismatch repair deficiency, Lynch syndrome genes, then immunotherapy is effective. And immunotherapy is one of the first drugs that was approved tumor agnostic. For any cancer that has those mutations, this treatment will work. It has an FDA approval. So that's kind of our one bucket. And the second bucket we have is PARP inhibitors. So PARP inhibitors is an oral medication that uses cancer's inability to restore DNA damages by knocking out the second mechanism to restore DNA damages. So, and with two DNA repair mechanisms disabled in the cell ends up dying. And so tumors that have one of those mechanisms impaired, so have BRCA2 mutations, BRCA1 mutations, ATM mutations, they end up not surviving, knocking out the second DNA repair mechanism by PARP inhibitors. And there's quite a few PARP inhibitors approved right now. The first approval was in a second-line metastatic castration-resistant setting. So folks that have had already chemotherapy, have had AR-targeted drugs, and now kind of moving to a second-line metastatic castration-resistant, and both olaparib and rucaparib are approved in that setting. And most recently, I would say within the last 4 to 6 months, we've had several FDA approvals in first-line metastatic castration-resistant setting of PARP inhibitors for patients with certain mutations. And if someone only had hormonal shots or only hormonal shots and chemotherapy and kind of haven't seen those newer hormonal drugs in a first line, when they progress, then in a first line castration resistant setting, they could use a combination of those newer hormonal drugs, abiraterone and enzalutamide type drugs, in combination with a PARP inhibitor. And we have olaparib, talazoparib, and rucaparib in that setting, and use it in combination, this kind of first line metastatic castration resistant setting for folks with BRCA1, 2 mutations is another FDA setting. I don't remember if we talked or not, but about 20% of patients with metastatic disease have those mutations in a somatic setting. About 12% have in germline setting. So overall, kind of 20 to 25% of people would be eligible for those treatments. And that's why we should be doing this testing.
Great, thank you for that. It's exciting that these drugs have come on the market and given patients more options. Justin, if there is an important genetic finding, what are the implications for the individual and their family?
Yeah, and so as Dr. Sokolova mentioned, a germline genetic test result, when we find these, there's broader implications compared to the tissue or the somatic genetic testing, where it's kind of very much treatment focused. And there's overlap, because if someone does have a germline genetic predisposition, all the medications that Dr. Sokolova mentioned, that person would be eligible for. And it would just be depending upon what type of mutation they have, if they have cancer, whereabouts they are in their diagnostic journey, the eligibility. And so there's that piece about if someone's diagnosed and they're diagnosed later on, and there's this question of systemic therapy. A lot of the things that Dr. Sokolova would mentioned are applicable to people who have these germline genetic findings. But then there's this kind of question about, well, what if someone doesn't have metastatic disease? Does this genetic finding have any implications? And then Dr. Sokolova mentioned the BRCA2 gene, which is, again, a gene that's very, very well studied in the context of breast, ovarian, prostate cancer. And we know that individuals who have this gene, if they do develop prostate cancer, their prostate cancer acts differently than prostate cancer in the general population. And so it may get some people who are oncologists who are treating local cancer to say, hey, should we take a more aggressive approach in treating, as opposed to the more kind of a less aggressive approach that we would do maybe for someone in the general population? There's not a lot of evidence or data to suggest that people should be changing practice when it comes to local prostate cancer. But something that you could have a discussion with, and that your oncologist may be able to talk with you a little bit more about, and may change some approaches, they may not. And if we were to go even lower in the diagnostic pathway for someone who has a very low-grade prostate cancer and is on something like active surveillance, and they're found to have a BRCA2 gene mutation, there might be some evidence to suggest that people on active surveillance with BRCA2 mutations, they may not stay on active surveillance too long. Their prostate cancer may upgrade or get to a point where they would need a medical intervention sooner. And so maybe there might be some more evidence to say, is BRCA2 something that we need to be factoring in when people are on their active surveillance journey, if they have that in the germline. So those are implications for them when it comes to their own diagnosis of prostate cancer. But if someone has a germline mutation, and again, it's inherited from the sperm or the egg, so that means that that mutation would be present in every cell in their body. These genes, their job is to repair DNA. And in certain tissues, they do that more often. And repairing DNA is really important, because if our cells don't repair DNA, our cells can accumulate mutations. And if you get the wrong mutations and the wrong genes, they can start becoming cancerous. So when it comes to a gene mutation like BRCA2, BRCA1, LB2, if someone has a mutation there, they're not only at risk for prostate cancer, but breast cancer. They're at elevated risk for pancreatic cancer. There's more evidence to suggest that there might be an elevated risk for stomach cancer. In women, people with ovaries, we see risk for ovarian cancer. The other genetic condition that was mentioned is Lynch syndrome. And so we see elevated prostate cancer risk in these individuals, but we also can see increased risk for colon cancer, uterine cancer, ovarian cancer, some genital urinary cancers. And so it might make us think, hey, if you have this gene mutation, prostate story, we got this under control. Now we have to start screening for other things that could be connected to this gene. So that's the individual. When it comes to the family, then we start thinking, okay, well, if this, again, cell's present in every cell in our body, if this gene mutation is present in every cell in our body, when it comes to our germ cells, our eggs, our sperm, 50% of them have the gene mutation. So that means there's a 50% chance this germline mutation is passed on to the next generation. So family members can get genetic testing to see if they have inherited this. And then we think about our parents. Well, we inherited from either the egg or the sperm. And so either a biological parent may have passed this on. And then we think about siblings, and we think about cousins, and then we think about nieces and nephews. And so it becomes a big family thing where we can say, hey, if you are unaffected by cancer, but you have this gene mutation, let's start screening you early. The NCCN just came out with guidelines saying if you have a BRCA gene mutation, BRCA1 or BRCA2, let's start PSA screening at age 40 every year. And so these guidelines and recommendations and rules are there for every cancer associated with every gene that we know today. And so it can become something that impacts the whole family pretty quickly. And it's an important thing to talk about so that, sometimes people are going and getting genetic testing because it's going to help their management. And then after everything's said and done, they sit back and think, okay, how am I going to talk to my kids about this now? And how am I going to talk to my siblings about this now? Because there's a 50% chance that this might be a part, or that risk for cancer might be a part of their life story too.
Thank you for that rundown. That was really helpful. And I think just to put a plug in, I know you both would agree with me. It's important to talk about this and talk about the family history and who, grandma had what type of cancer and when was she diagnosed, and and so, talk about all of this so you can be informed and then have these conversations with your doctor.
Yeah, and family history directly informs your personal management. And so if you don't have cancer, but you have a parent or a sibling who has had, for example, colon cancer, then if you tell your family doctor, hey, my brother had colon cancer, your doctor is going to think about your risk for colon cancer differently, might increase your screening. And so family history is really important and does change how the healthcare system perceives you, and oftentimes gives you more access to services.
Good point. Thank you. So, Dr. Sokolova, final question for our panel here before we go to audience questions. And we've talked a little bit, Justin alluded to this a bit too. Are there clinical trials available related to germline or tumor testing? Tell us more about those options.
I will start by piggybacking on Justin's discussion about cascade testing. I cannot emphasize this enough how important it is for both men and women to get family cascade testing. And I would say, unfortunately, historically, we've called it hereditary breast and ovarian cancer syndrome, which excluded men. And I think there's this kind of perspective that this is less relevant for men than it is for women. Or some men with prostate cancer think, oh, it's important only for my sons, not for my daughters. It is equally important for female and male family members. And one of the clinical trials that I do want to highlight today is one of the trials that we run here at OHSU, but available nationwide. It's about cascade testing, and it allows us to help do the testing in the families. So we take the burden off the patients, and patient says, hey, please talk to my son, my daughter, my sister about that they need their own testing. And so we reach out directly to them, we educate them about why they need it, and then we provide a free testing for them. And it's all done remotely. We talk to our participants over the phone, and we just mail the testing kits to their house. So if any of you still have family members that you kind of haven't approached or want to talk about, there would be some links associated with this talk that you can reach out and kind of direct them and to our study to do that. As far as studies, how to do the testing itself for the patients, one of the big studies that we've talked about, it's called the PROMISE, Prostate Cancer PROMISE. The beauty of this study is that you don't have to meet NCCN guidelines. You don't have to be thinking, oh, do I meet this particular criteria or not? If you have a prostate cancer diagnosis, you're eligible, period. So if you have a prostate cancer diagnosis, localized, high risk or low risk, biochemical recurrent or metastatic, you would be eligible. You can do it from the comfort of your home. You go online, you fill out some questionnaires, and there's quite a lot of questions, so there'll be some time dedication to that. But then again, the study team reviews your responses, and then they send the testing kit to your house. You spit in the tube, you put it in your mailbox, and you send it out, and then they call you with the results. So the study tries to remove a lot of barriers for our patients to get the testing done. And so those are one of the studies about the testing itself. There's also a lot of clinical trials around implications. And the two ones I want to highlight in an earlier setting. So when we talk about people with localized prostate cancer, at this point in time, there's no treatment implications for people with mutations with localized disease. But there's two clinical trials right now available in the US that offer treatment on a clinical trial basis. The Neptune trial offers neoadjuvant PARP inhibitors for those patients. So if you have a high-risk localized disease and you have BRCA1/2 mutations, you would be eligible to get a PARP inhibitor for 6 months, and then you go for surgery. And the second trial is a SWOG 2210. It offers chemotherapy, carboplatin chemotherapy for the same patient population. So people with BRCA1/2 mutations and a high-risk localized disease, before going for surgery, they will get 3 to 4 cycles of chemotherapy. And the hypothesis of both those studies is those patients with mutations, they have a risk of more aggressive disease. They have a poor prognosis. So trying to kind of really attack it with targeted treatments early on and then take them for surgery, hopefully will maximize the chances of cure.
Great. Well, that's exciting to not only to, we've partnered with the PROMISE study, so I think some of our viewers are probably aware of them and their work, but thank you for highlighting them. That's eligible to, as you said, all patients diagnosed with prostate cancer, but then it's exciting to hear about some of these other options too, as well. So now we will go to our audience questions. So remember, you can still get those in. You can even put them in the chat there, feature in YouTube. So first question is, I am almost 2 years into treatment for Gleason 9 localized EPE, which is, they say, proton therapy plus ADT and abiraterone. My oncologist is at a major medical center, hospital, but has not mentioned germline or somatic testing. At what point in my treatment should this testing take place?
I'm happy to take that.
Please.
I would say you can talk to your oncologist about this testing now, because you do have a high risk, so you meet the germline testing criteria. Somatic one, I think it's a little tricky. Currently, kind of the guidelines don't recommend in this disease space. On a case-by-case basis, we sometimes offer it if we think there's a really high chance of recurrence. But I would say germline testing you can definitely do, or you can just go ahead and click on the PROMISE link and kind of do your study. But you're definitely eligible for germline testing, and you can have it done now.
Thank you. We have one other, I'll ask this, but I'm not sure. This is a very advanced question. What effect does high ferritin, and we can keep it brief and as relevant to prostate cancer, I guess, as we can. What effect does high ferritin, whether from hereditary hemochromatosis or otherwise, have on prostate cancer inception and development? Go ahead.
This might not be my best world in that I'm not an oncologist. But yeah, there's many reasons for why someone might have high ferritin. I can speak to the hereditary hemochromatosis. When we think about hereditary hemochromatosis, I don't think about anything related to elevated risk for cancer. Hereditary hemochromatosis is a condition that you can treat just by doing a phlebotomy, giving blood. And so an altruistic gift to society, as well as decreasing your ferritin levels, but maybe trying to understand what the underlying causes of the elevated ferritin, whether it is a genetic factor or some of the other factors that can cause your ferritin to be elevated. But to my knowledge, individuals with hereditary hemochromatosis are not an increased risk for cancer.
Okay. Thank you.